All right, we're going to be talking about pneumonia. So the main differential for pneumonia and respiratory distress are bacterial, viral, and atypical pneumonias, foreign bodies, atypical mycobacterium, atelectasis, asthma, bronchiolitis, and bronchopulmonary dysplasia. Predisposing conditions, so we see viral pneumonia more so in children less than 5 than we do see bacterial. In children greater than 5, we see mycoplasma as well as bacterial pneumonia. Congenital heart disease, bronchopulmonary dysplasia, cystic fibrosis, asthma, sickle cell disease, neuromuscular diseases such as cerebral palsy, children with GERD and dysphagia and immunodeficiency disorders. All these types of patients can be predisposed to getting pneumonias and have a more difficult course. As far as pathophysiologic insults, common causes for bacterial pneumonia are strep and staph, and then atypical pneumonias are usually mycoplasma. For viruses, we worry about influenza, mycoplasma, parainfluenza, coronavirus, adenovirus, and there's plenty more as well. Bacteria and viruses are spread by droplet. With bacterial pneumonias, it's thought that a preceding viral illness weakens the respiratory defense and then allows the bacteria to infiltrate. And when that happens, it causes inflammation of the lower respiratory tract, and debris starts to accumulate, and then this decreases the lung compliance, making everything worse. So as far as manifestations go, it's important to remember that there's not one specific sign that will tell you this is pneumonia. And the younger the patient is, the harder it is to pick up. And so most patients will have fever, cough, increased work of breathing, and tachypnea, and then they will have crackles in a focal area. And this is different from bronchiolitis and asthma, where there may be crackles that are spread out or rotating. Also in pneumonia patients, they may or may not have egophony. And so if you remember, egophony is when we ask the patient to say E, and then when we auscultate, it sounds like A. So here's how it normally sounds. And then here's how it sounds with a person with a consolidation or pneumonia. So that gives you kind of a good little trick to use when you're wondering about a chest x-ray or other studies. And then lastly, they can have referred chest or abdominal pain. It's not uncommon to pick up a pneumonia on a CT of an abdomen because they're concerned about abdominal pain, and so they're wanting to rule out an API, and then you pick up a pneumonia in the lower lung fields. So as far as evaluation goes, we don't always get chest x-rays, but a lot of times it's helpful, again, just due to the age and the difficulty in picking it up. When we look at chest x-rays on a bacterial pneumonia, we should see an area of consolidation. If it's an atypical or viral pneumonia, we will see bilateral and diffuse infiltrates. If we're worried about an effusion, which typically can happen with MRSA, then we will get a chest ultrasound or CT to help decide if a chest tube needs to be placed. We typically do get a CBC and CRP. A CRP can be used to trend and see if there's resolution of the infection with the antibiotics. We may get a basic metabolic panel if we're worried about dehydration or if we're worried about SIADH from pneumonia. Lastly, a blood culture is usually a low yield, but if the patient is fairly sick, then it may be helpful in that scenario. As far as treatment goes, again, with community-acquired pneumonia, we're most worried about strep. So if it's oral, it's going to be amoxicillin. If it's IV, it will be ampicillin. If it's a complicated pneumonia, and a complicated pneumonia is a pneumonia with an effusion or empyema, or a pneumonia in a patient where they have failed the first-line therapy of amoxicillin or ampicillin. So in those instances, we will do ceftriaxone and clindamycin. And then as far as an atypical pneumonia goes, we will do azithromycin to cover for mycoplasma. So this covers our talk on pneumonia. If you have any questions, let your team know.